عليكم ورحمة الله. برحب بحضراتكم في المراجعة بتاعة الماسكولوسكيليتال سيستم.
Recording in progress.
وهنبتدي إن شاء الله الكيسز زي كل مرة بالكيس الأولانية، وزي ما احنا اتفقنا I will comment in English and you write your comments on the chat so that I can read it and I will finally comment on the case.
Synovial osteochondromatosis.
Yes, and actually we do not need the answers. We need the written answers. Okay. Yes, this is right. You answered the first question right, and this is the synovial osteochondromatosis. Because of the presence of a lot loose bodies within the ankle joint in the anterior mainly compartment, the loose bodies are of dark signal in whole bulk sequences. Sometimes they contain marrow, especially in the larger bodies. Then the second case.
Adhesive capsulitis.
Okay. Yes, and this is a slab injury because if you look carefully to the superior labrum, then you see an abnormal bright signal in the superior labrum, and this bright signal means that there is a slab injury, but you are not sure about the thickness of the inferior glenohumeral ligament because of the absence of fluid in the joint. And this is important if you want to assess carefully the inferior glenohumeral ligament. You should have some fluid inside the joint. The next case.
Hemophilic pseudotumor.
Okay, and I would like to look at your answers on the chat. The first one was synovial osteochondromatosis and nothing more. Yes, okay, this is because of the history, and history is very important here. This is a hemophilic patient presented by a sudden onset of pain in the gluteal region with no history of trauma or fever. Then you should assume a hemophilic pseudotumor because this is one of the common sites for hemophilic pseudotumor. And here you can see that there are some hyperdensities within the lesion, which is eroding the iliac bone. The hemophilic pseudotumors are classically most common in the femur as well as in the iliac bone. They represent about 1 to 2 occur in 1 to 2 percent of the. Okay, why I am muted? Then they occur in an incidence of 1 to 2% in patients with hemophilia, and according to the literature, it is usually contraindicated to have a biopsy from this lesion because of the possibility of bleeding, of course. But whenever you know from the history that the patient is hemophilic, then you can easily interpret this as a hemophilic pseudotumor. Next case. Nothing came to me from the chat, but okay, if you want to answer by your voice. Okay, Dr. Sharif, let them answer by their voice.
Vascular necrosis of the head of the femurs.
No? Other possibilities?
Perthes disease.
No? There are three participants would like to answer.
Septic arthritis.
Yes, and this is right. And of course, whenever you are dealing with any joint, then you should look carefully where is the disease. Is it in the femoral head only, or it affects also the acetabulum? If both are affected, then this is joint disease, not a bone disease. And the joint disease, which is has eroded the acetabulum and eroded most of the femoral head with widening of the joint space, and these are classic features for the septic arthritis. Okay, next case. Yes. Okay. I cannot hear the answer, of course. Okay, what do you think about this MRI of the hip joints?
Ganglion cyst.
Where ganglion cyst?
Bursitis.
Bursitis,
Bursitis.
which bursa?
Psoas.
Iliopsoas bursa, yes, and this is iliopsoas bursitis. The classic location of the iliopsoas bursa is between the iliopsoas muscle and the vessels. Then the bursa is connected to the joint, and sometimes there is a significant joint effusion which is decompressed through the bursa itself. Next case. Yeah. Okay. Please answer quickly so that we can give you the time.
Do you want to allow them all to unmute themselves or
Yes, and there
stay
is,
to the settings?
yeah, and psoriasis, no. And another possibility,
Degenerative arthritis.
yes, is osteoarthritis of the interphalangeal joints, and then this is a right answer, or the erosive osteoarthritis, which simulates the birds in the sky, as you all know. This is MRI of the shoulder. What is the problem here?
Subscapular ligament tear.
With subscapular ligament? There is no ligament.
Tendon.
Tendon? Subscapularis,
Yes.
you mean?
Yes.
Is a
Subscapular.
subscapularis tendon
And
partial tear or complete tear?
infraspinatus.
Infraspinatus is intact. And this is the subscapularis. What do you think? Is it a full thickness tear or partial thickness tear?
Partial.
Partial thickness tear. What do you think of this
Yes.
structure? Yeah. Okay, this is the middle glenohumeral ligament, which is located between the subscapularis tendon and the anterior lemur. And this is partial subscapularis tendon tear. Then next case.
Charcot joint.
Yes, and this is a Charcot joint. The diagnosis is well known to the patient, and he is now looking for the presence of osteomyelitis. Then, if you look carefully here, and you got the manifestations of Charcot joint in the form of destruction, sclerosis, and derangement of the joints. But the presence of osteomyelitis is indicated by the presence of soft tissue edema as well as the presence of bone marrow edema, which are not present here. Next case.
This is Morton neuroma.
Yes, and this is Morton neuroma, classic location, classic appearance, or dumbbell-shaped lesion, which is present in the third metatarsal space. And you know that this is not an actual neuroma, but it represents a granulation tissue or perineural fibrosis around the interdigital nerve, especially in the third space, and sometimes it can occur also in the second space. In about 10% of the patients, you got bilateral lesions, and the lesion is classically of low signal in T1 and T2 weighted images and shows contrast enhancement after injection of contrast. It has a very classic appearance. Sometimes it is not actually insinuated between the metatarsals. It may have its main bulk at the dorsum of the foot or in the plantar aspect of the foot. Next case.
Supraspinatus
Yes.
complete.
Yes, a supraspinatus full thickness tear with retraction. You should measure the distance between the four edges of the tendon, and also you look to the street of the
Complete
placenta.
tear supraspinatus.
Sorry. These voices will disturb the recorded video. Then I suggested that you refer to the chat and you train yourself for the next revisions, that you can answer by writing the answer in the chat, and I read it and I comment. Then we can avoid all these outside noises that can decrease the quality of the recorded lecture. Then the next case. Yes, any answer? If you want to write the answer, write only one word or two, so that you can deliver me your opinion. And here we have an answer: calcanean fracture. No, this is not calcanean fracture. Any other possibility? And this is normal foot. Okay. We can look here, and if you look carefully, then you can see that there is some erosive changes in this particular area, and you got some decreased bone density in the tarsal bones. Then this is the MRI of the same case. This is T1 and T2 and T1 post contrast with fat suppression. What do you think? Okay. Osteomyelitis, good answer. Any other possibilities? All right. Then what you see here is bone marrow edema of the calcaneus and the cuboid bone. And also you can see haziness of the cortical margins corresponding to the erosion seen in the plain film. And also you got some synovial fluid with synovial thickening as well as the marginal enhancement of the soft tissues and also inside the bone. All these features are impressive of osteomyelitis together with septic arthritis, and this patient had proved to be tuberculous osteomyelitis as confirmed by aspiration of the joint fluid. Next case. Okay. Chronic repetitive osteomyelitis and another possibility multiple myeloma. Then if you look carefully to the age of the patient, and this is not the age of myeloma, and also these are not the locations of myeloma, but the first answer was right, where you got some erosive changes associated with sclerotic bone reaction, especially in the tibia, especially in the proximal part. Sometimes it can affect the proximal humerus, and the diagnosis is chronic recurrent multifocal osteomyelitis. Actually, this disease is frequently seen in the clinical practice in the current days. So I would like you to know about this particular disease. This is an idiopathic inflammatory bone disorder seen in children and adolescents. It's more common in females, and if you got a biopsy from this lesion, you will not find any organism. And you know that this is chronic, recurrent, multifocal, so that it can come back, and there is no signs or symptoms of significant infection. But sometimes you got mild fever, you got weight loss, and the most common site is the tibia, and the clavicle usually involved. But if you see clavicular involvement, this is pathognomonic for this disease. So all what you will see are multiple areas of bone marrow edema scattered everywhere in the skeleton. You see, it will affect the metaphyses or the regions near to the metaphyses, in the anterior chest wall, long tubular bones. The clavicle is one of the famous bones that is affected in this particular disease, which can also occur in the spine, in the pelvis, and sacroiliac joints, in the ribs, and in the sternum. So, how can you pick up the diagnosis? Number one, multiple areas of bone marrow edema scattered all over the skeleton. The age of the patient is in the let us say teenaged, in the childhood or the adolescence. Then the patient will complain of pain, but frequently you got no signs of inflammation. Then this is the second case, and the next case I mean, and this is MRI of the knee of patient with history of ACL reconstruction. And what is your opinion in the graft? Uh, Okay, this is graft failure with fusion, failed graft. Yes, this is right. The graft is failed because in this image you cannot see intact fibers along the course of the graft, and you see some fluid inside the joint, and this is an indication of graft failure, whatever the duration between imaging and the surgery. But if the duration is still in the first year, then if you see some fibers and some abnormal signaling, you say that this is the phase of ligamentization of the graft. But this case there is total graft failure. In this case you got metaphyseal bone sclerosis. And actually, there is a long list of possibilities for this. But actually, in the exam, we would like you to mention one or two of the lesions that can be associated with metaphyseal bone sclerosis. Yeah, rickets, ochronosis, healed rickets. Okay, actually, you know that this case was proved to be sclerotic metaphyseal band secondary to lead poisoning. Then I would like to show you the common lesions that can be associated with metaphyseal bone sclerosis, like chronic anemia, including sickle cell and thalassemia, chemotherapy, especially the methotrexate, gross acceleration lines forming the gross arrest due to systemic illness, stresses in infancy like asthma, diabetes, and cystic fibrosis, lead poisoning, treated leukemia, normal variant sometimes, renal osteodystrophy, healing rickets, as you said, then sometimes in cases of trauma. There are uncommon diseases that can be associated with metaphyseal bone sclerosis, like biphosphonate therapy, chronic recurrent multifocal osteomyelitis that has been mentioned, congenital transplacental infection, including the torch possibilities, drug or hormone therapy in high dosages like steroids or parathyroid hormone, heavy metal or chemical poisoning, as mentioned, hypoparathyroidism, hypothyroidism, meconium peritonitis, metaphyseal chondrodysplasia, osteopetrosis, oxalosis, parathyroid hormone therapy, healing scurvy, spondyloepiphyseal dysplasia, spondylometaphyseal dysplasia, vascular injury, and idiopathic hypercalcemia. Next case. This is axial stair and sagittal T1 showing a patellar pathology. What do you think? Uh, Someone said Alta. I don't know what does it mean, but ABC is a very good possibility, and as many of you have said this. This is aneurysmal bone cyst of the patella, which is an odd site for the aneurysmal bone cyst. But if you look carefully in the stair image, you can see some fluid levels, which is one of the characteristics of aneurysmal bone cyst. And this patient with pain in the left ankle joint, and you see this is sagittal stair and axial T1. Yes. Well, its name is not Holland, but Haglund syndrome, if you want to say that. And this is not torn Achilles tendon. If you look carefully in the axial images, and you can see some abnormalities inside the substance of the tendon, which is almost intact. Then if you got abnormal signal, yes, this is tendinosis, I agree. And this is Achilles tendinosis. You diagnose Achilles tendonitis or tendinosis by abnormal signal and sometimes increased caliber of the tendon, but the tendon remains intact. The next case is MRI of the knee, sagittal T1 and the sagittal stair. Lipoma arborescens, yes, this is right, lipoma arborescens, and you got inside the knee joint a big mass formed of fat signal, bright in the T1 and dark in the stair images, embedded within a big amount of joint fluid. If you see this appearance and this frond-like appearance is known as lipoma arborescens. But if you got a mass of fat inside the joint, and this is synovial lipoma. Next case. Brown tumor of hyperparathyroidism. Then this is the possibility answered by you. Other possibilities? Okay, actually, you got an expanding lesion in the head of the humerus with matrix calcification. Inchondroma is a good answer, and this actually was an inchondrome. Enchondroma in the long bones usually do not cause expansion of the bone, but sometimes you got this appearance, and this is you cannot diagnose the brown tumor unless you have other evidences in the clinical or in the remaining radiographs of the presence of hyperparathyroidism. And you know that the brown tumor do not contain calcium until the patient receives therapy for hyperparathyroidism. It's a purely osteolytic expanding lesion. Next case. Okay, supraspinatus tear, complete tear, yes, supraspinatus complete tear. And you know that for supraspinatus tear, you should mention the distance between the cut edges of the tendon, and you should mention also the state of the muscle, if it is atrophic or not. But this muscle is not atrophic because of the absence of fat streaks within the muscle fibers itself. Then this is the hand X-ray of a male, 32 years old. Inchondroma. Okay. And let's inchondroma is a good possibility, and you cannot actually separate the inchondroma from the giant cell tumor. But many times you got that the inchondroma does not cause significant expansion. The giant cell tumor may contain some trabeculae inside, but actually I went through the literature and I cannot or I could not find a single criteria that can differentiate between inchondroma and giant cell tumor. So in cases where the age is above the age of epiphyseal closure, then you may consider also giant cell tumor in the differential diagnosis of these tumors in the hand. Next case. Achilles full thickness tear, osteochondritis dissecans, complete Achilles tendon tear. Okay, yes, and this is full thickness tear of the Achilles tendon. In cases of torn Achilles tendon, you measure the gap between the cut edges of the tendon and you measure the distance from the torn edge to the insertion site in the calcaneus. And in the previous days, we used also to mention what is in the gap. Is it fluid or blood or fat? And this finding or this information is no more of value, but all what is needed is to measure the gap and to measure the distance from the cut edge to the insertion site of the Achilles tendon. Then next case. Lymphoma or metastasis, and consider this is a young person with classic appearance in the yes, very good, this is chondroblastoma. And the chondroblastoma is a lesion that is classically located in the pedicle of a young person and is associated with some bone sclerosis and the classic appearance of a scoliotic deformity with its concavity towards the site of the lesion. And in the MRI, and you got this lesion in the pedicle of the vertebra associated with bone marrow edema of the vertebra itself and maybe of the above vertebra as well. Actually, you cannot diagnose osteoblastoma in the skeleton unless it has this classic appearance in the spine of a young person with sclerotic reaction and scoliotic deformity towards the lesion. Next case. There is a question why there is edema. Any of the bone tumors, because of the reaction in the mother bone or the adjacent bones, then you got bone marrow edema, even if this tumor is benign. And the answer is D, which means that this is an osteochondroma or cartilage capped exostosis. This is right. Then the next case. And the answer came to me, alapsa or superior labral tear. other possibilities. And superior, this is actually an axial image. Yes, this is the reverse of Bankert. This is the right answer. The reverse of Bankert is known now as the posterior Bankert lesion. You know that Bankert lesion is torn of the anterior labrum as well as its attachment, periosteal attachment to the scapula. And the reverse of Bankert lesion is now known as the posterior Bankert in the literature, where you got tear in the posterior labrum as well as its connecting periosteum. Next case. Okay, this is an X-ray of the hands showing extensive calcifications in the along the shafts of the phalanges mainly, and sometimes along the shafts of the metacarpal bones. Yes, the answer is dermatomyositis, as Nahla said, and this is dermatomyositis. The calcium is confined to the subcutaneous area, and the bone density is preserved. The phalangeal tufts are not eroded, and this can differentiate dermatomyositis from scleroderma, of course. Scleroderma is associated with erosive changes of the phalangeal tufts and contractions of the joints. This dermatomyositis is an autoimmune inflammatory myositis, and it has a risk of malignancy, and there is a recognized female predilection with two types, the juvenile type and the adult type, which is seen in adults around the age of 50 years. There are classic presentations affecting the proximal myopathy with skin changes, as you see here, dusky red rash over the face, arm, hand, leg, and also you may got dysphagia, myalgia, fever, and weight loss. The possibility of malignancy is six folds with in the presence of dermatomyositis, and these are the risk factors for the development of malignancy. Males above the age of 60, the presence of dysphagia, accelerated onset of the disease, skin necrosis and cutaneous vasculitis, as you can see here, increase creatine kinase level, increase ESR and C-reactive protein levels, interstitial lung disease, inflammatory arthropathy, and Raynaud's syndrome. Next case. Yes, and giant cell tumor is a very good answer, and I would like you to remember this possibility in the differential diagnosis, which is the chondromyxoid fibrome. You can also not be able to differentiate between giant cell tumor and chondromyxoid fibrome, but because of the familiar or the common incidence of giant cell tumor, we usually diagnose these lesions as giant cell tumor, and it came sometimes that the histopathology was a chondromyxoid fibroma. You know that chondromyxoid fibroma is a benign lesion, while giant cell tumor is locally malignant tumor, which may turn after that as a malignant lesion. Next case. This is an elbow of an X-ray elbow of a young child. Olecranon fracture, tendon avulsion. These are the suggestions. And then, Sabir, what do you mean by tendon avulsion? Um, okay, you know, in the pediatric age group, interpretation of the elbow X-rays is somewhat very difficult, and you need the opposite elbow to compare because of the great number of the ossification centers that have not yet united. And this is normal appearance of the olecranian ossification center, and this also, but the abnormality is here in the capitulum. And you got some radiolucency and the bone sclerosis, and this is diagnostic of capitulum osteonecrosis. Osteonecrosis of the capitulum is a self-limiting disease, and it can heal completely without any damage to the joint. Then next case. No, this is not an ACL tear. Mycoid degeneration, yes, this is right. This is ACL mycoid degeneration. You know the ciliary stalk sign, and you got big or significant swelling of the ligament with some intact fibers running side by side to the degenerated fibers, which show abnormal signal. Next case. Simple bone cyst, non-ossifying fibroma. Okay, and you remember that simple bone cyst is an expanding lesion that is located mainly in the proximal femur and the proximal humerus. And non-ossifying fibroma is a cortically based lesion, and it usually shows low signal in all bulk sequences because of the fibrous component of the tissue. But you remember that I have mentioned in the lecture of the knee joint that you may sometimes incidentally found this lesion, which is located intramedullary. It shows low signal in the T1 and relative bright signal in the T2, with very bright signal in the STIR images, together with the presence of dark foci within the lesion representing calcium, and this is in chondroma of the long bone. Yes, then this is the next case. Yes, right, very right, very good, Nahla. And then this is Bolapsa or the reverse of alapsa. You see that there is a tear of the posterior labrum with intact perosteum and somewhat medial displacement of the torn labrum, and this is prolapsa and the reverse of alapsa. Then this is the right answer. I hope you can answer this case correctly based on the previously mentioned informations. No, this is not migratory osteoporosis, and this is not metastatic deposits. You see, this is a child, and all what you got here is bone marrow edema in the right iliac bone, as well as bone marrow edema in the proximal left femur. Yes, and this is chromo, as I have mentioned before, multifocal osteomyelitis, and I said that this lesion is frequently seen in the clinical practice, and then you should remember this possibility. You got a young person with multiple areas of bone marrow edema, no history of trauma, and no significant signs of infection. Then one of the classic history also, whenever you hear it, is the recurrence. The recurrence. This is a recurrent disease. And I see a case a few weeks ago, and the father of the patient said that he was ill, then recovered, then complain once more of the same symptoms. Then this is one of the criteria to suggest the diagnosis. Next case. Calcific tendinitis, yes, Ahmed, this is right, calcific tendinitis. And you got in the plain X-ray these foci of calcium along the insertion site of the supraspinatus tendon, which are not clearly seen in the MRI because of the low signal of the calcium as well as the low signal of the tendon itself. Next case. Osteoarthritis. This is a child. Osteomyelitis. And if you look carefully, and you got the soft tissue mass extraosseous together with abnormal signal of the acetabulum, the mass is not with osteomyelitis. The mass is with bone tumors. And you remember that one of the criteria of malignant tumors is the presence of extraosseous soft tissue component. Then, if you look here, and you got some erosive changes, which can be interpreted as septic arthritis or something like this. But on MRI, whenever you see an extraosseous soft tissue mass, then you think of malignancy. And then the malignancy, of course, in this age group, as Ahmed said, is the Ewing sarcoma. And this is right, this is Ewing sarcoma, And one, you should remember this very carefully. One of the criteria of malignancy is the presence of an extraosseous soft tissue component. This patient had bronchogenic carcinoma, and this is the X-ray of the knee done because of pain. Is it a normal X-ray, or there is an abnormality? And if there is an abnormality, where? Metastasis to the patella. Riaz said this is metastasis in the patella, and this is right. If you look carefully, you see some osteolytic lesion in the patella, and this is the MRI of the same case where you got an infiltrative lesion in the proximal part of the patella, which is in the presence of lung cancer, is diagnostic of metastatic deposit. Yes, and this is an X-ray of the hip and the frontal view and the lateral view. What do you think? Osteochondromatosis, the Riaz said, and this is right. Osteochondromatosis, you got multiple loose bodies in the inferior aspect of the joint, and this is the CT scan. Actually, you may diagnose this lesion very easily from the plain film, but sometimes they present this case as as a spot case in the exam, and you have to spend some time thinking about these calcific structures, and you should consider this as synovial osteochondromatosis. Next case is an MRI of the wrist joint in the coronal view stair image. Yes, TSF, TFC tear, Nahla said, and most of you answered the case correctly, and you got a defect in the fibrocartilage and along its attachment to the radius, with consequent leakage of fluid from the proximal radiocarpal and radioulnar joint into the this space, which is the distal radioulnar joint. This joint is the the radiocarpal joint, of course, and this is triangular fibrocartilage tear. This is actually an easy case, and the illustrations are also provided. This is bucket handle tear. Yes, you got the well-known sign, which is the double BCL sign, and this is the stages of the formation of the bucket handle tear, which starts as the short longitudinal tear, then became longer, then the medial fragment is displaced underneath the posterior cruciate ligament, and this is bucket handle tear. This patient is a smoker, and the chest X-ray showed bronchogenic carcinoma. These are the plain X-rays of the femur and the spine and the pelvis. Paraneoplastic syndrome, Nahla said. Other possibilities. Hyperbara, Ahmed said. Okay, metastasis, Reham said, and let us verify the findings. Actually, you got the classic appearance of ankylosing spondylitis with calcification of the spinal ligaments as well as obliteration of the sacroiliac joints. You know that the paraneoplastic syndrome is just a perosteal reaction along the shafts of the long bones. Then if you look carefully in this femoral shaft, and you got destructive changes in the cortex of the bone and osteolytic lesion within the medullary cavity. Then there is no contradiction between the presence of ankylosing spondylitis and the bronchogenic carcinoma. So many times when they provide you the history easily in the exam, this is misleading. Though bronchogenic carcinoma is associated with metastatic deposit in the shaft of the femur, but the patient had another problem which is unrelated to the bronchogenic carcinoma, which is ankylosing spondylitis. Then this is MRI, coronal T1, axial stare, coronal stare. Vascular necrosis, Nahla, yes, this is right answer. And Reham also, this is a vascular necrosis of the femoral head. And you got an abnormal lesion in the subcortical area of the femur. And if you look carefully, this is fluid signal, low in T1, high in the stare, denoting the stage B of a vascular necrosis. And this is also an easy question. Meniscal separation, capsular detachment, yes. And this is not a vertical tear in the posterior horn of the meniscus, because the posterior horn is almost intact, but there is a defect at its base. With the defect is filled by fluid signal, and this is the meniscocapsular separation, which is known now in the literature as ramp lesion. Then if you are confronted in the exam by this ramp lesion, you know that this is nothing but meniscocapsular separation of the posterior horn of the medial meniscus. Next case. Plantar fasciitis, very good. And yes, most of the answers are going to the right way, and this is plantar fasciitis. Plantar fasciitis is one of the causes of pain in the foot, especially in the inferior aspect, and you should carefully look for this in every case. The manifestations, as you know, is thickening of the plantar fascia, abnormal signal, and also edematous changes in the subcutaneous fat, and many times in in the insertion in the calcaneus at the insertion site or the attachment site of the plantar fascia. Next case. Chondrosarcoma and sarcoma, chondrosarcoma. Oh yes, very good. This is actually a chondrosarcoma is the right answer because you got a malignant lesion and this lesion contains calcium, although the calcium is not evident on MRI, but one of the values of MRI is to see this part of the lesion across the iliac bone, and another finding is to look at the brightness of the lesion in the T2 weighted images, which is one of the criteria of chondromatous tumors like chondrosarcoma and chordoma. Next case. Paget, osteoma, metastasis, osteoma. Yes, the right answer is Paget disease because number one, enlargement of the bone. Number two, heterogeneous texture of the bone, including sclerosis and osteolysis. Number three, the severe intense uptake by the bone scan, which is known as the super scan. And there is also one of the criteria mentioned in the literature is the presence of the mouse face in the spine, because this vertebra is affected together with the pedicles, giving this characteristic appearance. Of course, you do not see this in every case, but you consider the enlargement of the bone and the heterogeneous texture of mixed sclerosis and osteolysis is diagnostic of Paget disease. Next case. Yes, and this is right. Bucket handle tear. A straightforward case with double BCL sign. And whenever you are confronted by a similar case in the spot exam, don't say that this is double BCL sign, but you say that the correct diagnosis, which is bucket handle tear of the posterior horn of the medial meniscus. And sometimes many of the cases in many of the candidates, whenever they see a case of mycoid degeneration of the ACL, they said in the answer, this is ciliary stalk sign. But this is not the right answer, of course. The answer is mycoid degeneration in the example, and in this case, the bucket handle tear. This next case. Frozen shoulder, very good. This is the right answer of frozen shoulder or adhesive capsulitis, diagnosed by marked thickening and the shortening of the inferior glenohumeral ligament. This is a good answer. And you should remember that frozen shoulder is a clinical diagnosis And you can diagnose this from the clinical point of view. Even the MRI is absolutely normal. Next case. Lymphoma, yes, this is right. The answer is lymphoma. You know that an infiltrative bone tumor, especially after the epiphyseal closure, without significant extraosseous soft tissue component, and with the presence of some sclerotic texture in the plain X-ray or CT, all these features suggest the possibility of lymphoma. Next case. Osteonecrosis, yes, this is right. Osteochondritis dissecans, vascular necrosis, all these answers are right. And this is not, of course, chondromalacia patella, but this is an osteochondritis dissecans, which is commonly affects the femoral condyle, the medial femoral condyle, but it can also occur sometimes in the ankle and sometimes in the patella. And you got separation of the fragment as you can see here. Then this patient with MRI of the side T1 and T2 weighted images, lymphoma, B, grade 2 muscle injury, hematoma. Yes, right. This is bright lesion in the T1 and also bright lesion in the T2 weighted images, indicating the presence of blood. And the blood within the muscle is an indication of grade 2 muscle injury, grade 1 muscle edema, grade 2 muscle hematoma, grade 3 muscle disruption and atrophic changes. This is grade 2 muscle injury or intramuscular hematoma. Next case is an MRI of the elbow, axial and sagittal stair images. Biceps tear, biceps tear. The biceps tendon reaches its insertion. It looks intact, and this is right answer, which is the biceps tendinosis. Yes, the biceps tendon is intact. And you remember that if the biceps tendon is torn, it will be retracted up in the arm with a wavy outline and so on. But this tendon has reached its attachment in the radius, but there is some abnormal signal and some fluid around the tendon, which indicates the tendinitis or tendinosis, but not tear of the biceps tendon. Okay, next case. Bone infarction, right answer. This is the classic appearance of bone infarction in the plain X-ray and also in the CT scan. You see intramedullary bizarre shaped calcification, or what's known as the Chinese figures. In the T1 you got low signal, in the T2 you got some high signal with a line of dark signal outlining the lesion. This is a classic appearance of medullary bone infarct, and sometimes, and I have seen reports misinterpreting this as lymphoma and metastasis. This is absolutely wrong. Next case. Yes, the right answer is Haglund syndrome. And you know, Haglund syndrome is composed of three findings. Number one is the presence of fluid in the retrocalcanean bursa, fluid in the subcutaneous tissues superficial to the Achilles tendon, and swelling with some intermediate signal within the Achilles tendon. And this is the criteria of Haglund syndrome. Next case. C, which means Brod's abscess, and yes, C is the Brod's abscess. The answer is right. This is an intramedullary lesion with some criteria of high signal margin in the T1 weighted image, surrounded by evident bone marrow edema, as you can see in the T1 and the stir images. This is classic appearance of Brod's abscess. Brod's abscess is an intraosseous abscess, and it is a form of subacute biogenic osteomyelitis, usually seen in children, more frequently in boys than girls. And this is the causative organism is usually the Staph aureus. It occurs in the metaphyses of the tubular bones. The proximal and distal tibial metaphyses are the most common, and this lesion is surrounded by a sclerotic margin in the plain X-ray and the CT. What's known as a penumbra sign is one of the criteria of this lesion according to the literature, which means that there is a high signal intensity margin in the T1 weighted image surrounding this abscess, which can cross the physial plate and extend into the epiphysis. Next case. Yes, and this is ABC or aneurysmal bone cyst. Classic location, classic appearance. Aneurysmal bone cyst is showed multiple fluid levels. Is an expanding lesion. Is frequently seen in the spine, affecting the pedicle part of the vertebra and part of the neural arches. Next case. Mm, the, yes, they said that this is some of the candidates said that this is talofibular, and others said that this is tibiofibular. The right answer is tibiofibular. This is the normal appearance of the anterior tibiofibular ligament, and this is the posterior tibiofibular ligament. And in this case, you got rupture of the anterior tibiofibular ligament with fluid signal at the site of the rupture. In the current literature, this is known as high ankle sprain. High ankle sprain is an injury to the anterior tibiofibular ligament, and this is the mechanism of injury involves external rotation and hyperdorsiflexion of the ankle. This injury is a frequent injury in the athletes, and it accounts for 25% of ankle injuries in athletic patient and athletic people. Then it takes somewhat longer days to recover, from 15 to 45 days. and there is tenderness over the syndesmotic complex. You know that the syndesmosis is the attachment between the tibia and the talus. Then if you got tenderness here, and this is one of the diagnostic criteria,